Hello and welcome to the Dental Labcast. My name is Jenna.
My name is Andrea.
Please follow and subscribe to support our show and to make sure that you never miss an episode.
Welcome to the next episode of the Dental Labcast.
Hello and welcome to today's episode of the Dental Labcast. My name is Jenna.
My name is Andrea.
And today we have got Sean Ward. Sean briefly started his career in the RAF and then he went on to study dental technology. So Sean, if you'd like to introduce yourself a bit more and tell us how you got into dental technology.
Yeah, evening everyone. I hope you're fine. It was a strange one. Once I left the forces, ended up having a couple of contract jobs engineering, and it was around the time of Black Wednesday, for those who are old enough to remember that, in the mid-90s, and I was working in the caravan industry at the time, and the bottom fell out of the leisure industry because of the high interest rates, and I just decided to go back to college and do something else. And I had a look around, looked at some university bits and pieces, and I seen dental technology and didn't have a clue what it was, didn't know anything about it. And so I applied for that, and here I am.
It seems like quite a common theme, doesn't it? That most people say, I knew nothing about dental technology at all.
Really does.
To me, it's engineering on a smaller scale, but before I got into it at all, I didn't have a clue, you know. The reason I went for it was a qualification which would also teach you a skill. But little did I realize at the time, the skill would just be the basics, and it would take at least 10 years to develop into something that, I'm not going to say which is good, but it's something which is reasonable. I've just got a better understanding now than anything I had when, 30 years ago now.
So you've been in dental technology for 30 years?
Yeah, and that was as a mature student as well. So obviously with it being my second career.
So how old was you when you actually started dental technology then?
I was 29. I started dental technology.
Wow.
Oh, baby, I was older than that when I started.
And you've gone on to now further your career and do clinical dental technology, haven't you?
Yeah, I was a mature student again. And it was basically I'd thought about doing it probably about 8 or 9 years ago, and I thought, no, I don't mind being at the bench. I'll just see how we go. See, COVID happened, and it was a case of, do I just chuck it all or do something else? And I applied, I think in beginning of 2021, and luckily I was successful and got on the course then. It was a massive learning curve for me going back into higher education. So the biggest shock was when I went to the library and couldn't find any books.
Everything's online nowadays, isn't it?
Well, yeah. And I even asked, I said, so how do I find this? Yeah, just use a computer. And I says, look, idiot, can't use a computer.
So do you mind me asking how old you were when you actually started studying for clinical dental technology?
I think I was, 55.
Wow.
54. I know I don't look it. So I think that, 2021, yeah, 55, 56.
And what made you want to actually go from being just a dental technician to being a clinical dental technician? What pushed you and motivated you to do that?
It's part of the reason was to stay in the industry. And once you reach a certain level, unless you're lucky enough to get to, say, higher education elsewhere, which was, I'm not going to say it's an issue, but I had kids, still got kids, but they're older. But you built a life for the last 20 years up in Scotland. 25 years I've been up here now, and you've got a home, and there's very little higher education in the dental industry up here. So there's no way you could go on and do a degree. There's no way you could do a master's unless you were doing some sort of distance learning. And as regards to that, all the jobs that come up elsewhere now, if you wanted to improve, the minimum is a degree. They don't look at experience, they look at the qualification first. And the opening jobs as well, they're very poorly paid, especially in the hospitals. They really try and drive it down, but whether that's the the NHS or whether that is the lab manager on a budget. But to me, it's a case of, yeah, you've got a budget, but if you've got the right candidate and that's the candidate you want, that's the candidate you want. So it's up to then the lab manager to fight his corner if he thinks, no, this is who we want and this is what we're paying him. So I think sometimes I use a term a lot. I used to call it accidental management until I found out it was called the Peter Principle, which is well known. You get somebody who's good, so they promote them until they're useless because they can't manage. And that's
Not
what
everyone's
happens.
made to be a manager, are they? Not everyone
No,
can
not
lead,
at all.
no
Not at
matter
all.
how skilled they are at their actual job. It doesn't mean that they can actually manage or lead a team of people.
Yeah. And I've seen that happen throughout the industry, and it's probably one of the worst, especially in the commercial side. It's probably one of the worst industries. They look at the person who makes them the most money or who's the best, but they're absolutely rubbish at team leading or trying to get the best out of other people, or because when you step into management, your job changes completely.
And I think that's the thing with a lot of technicians as well, isn't it? We're taught to be technicians, and we're allowed, as you said in the previous episode, Jenna, we can go and open up a lab as soon as we're qualified, but
Yeah.
you don't get taught how to run a business. You don't get taught any of those business management skills, those accounting skills, those people management skills, all those skills that are associated with that side of things. So you've got someone who's a good technician trying to fumble the way through the rest and hope they don't mess it up.
Yeah, and there's a lot of things to work through, isn't there, as well with that?
Mm.
There's a big learning curve when it comes to actually running your own business as well as doing the work alongside it.
It doesn't help as well. Attitudes as well for some people. It's I like to think myself as quite level-headed and open-minded, and it's some of the attitudes of people my age or people younger. Well, I had to do it when I was a trainee, and I had to do this when I says, yeah, but times have changed. You can't speak to people in a certain. You've just got to be aware of so much now. And some of them don't care, but you see it as well with some labs with a high turnover over of staff that they have. Especially in lower positions. So
How many years have you actually owned your own business? Because you owned your own lab as well, or still
yes,
do, I believe, don't you?
so yeah. 12 years this July I've been in business.
And how did you find it, especially
Very
when you
hard.
started out?
Yeah, very hard. Yeah. Again, if you're not producing, you're not making money. So you spend time either trying to learn something, you're not making money. You spend time doing paperwork, you're not making money. It's things like that. You spend time on the phone, and you're not making money, anything like that. So that's perhaps the worst part of it. Everyone says you work for yourself, you're in control of your hours, and yeah, that's great. I'm in control of about 60 to 70 hours a week. When I first started, it was probably 80, 85 hours a week. It has come down a lot, so I get my weekends now, so that's a bonus.
How do you split your hours between lab and your CDT work now? Do you have your own CDT clinic? Do you work with a dentist in their clinic?
Right, I work in general practice 1 day a week in a local one in Kirriemuir, which is about 5 miles from here, and that's flourished. I see all the patients, whether they're NHS, private, or dental plan patients. And if they need teeth, the two principals there, they just say, "Oh, you just go and see Sean," and that's it. And I work in a practice in Dundee for an afternoon every other week. And I do like on-call work, not necessarily on call, but if there's a couple of practices I'll go to if they've got a patient that they want me to see. So I do it that way. So it's usually 3 days in the lab, a day and a half in clinic, and then a half a day. I just class that as running around time. When you've got to get things done. So
We're probably going to jump back and forth between some questions here, but when we was talking about business,
yeah.
you're also an associate tutor for the Cardiff Metropolitan University. Do
Yeah.
you think that on these courses they should bring in some sort of business aspect to teach students if they do want to open their own dental lab?
Probably should be taught as regards to, basic accounting. That was the biggest issue I had. Dental technologies, it's as a craft, I've heard it called, as well as a profession. I've heard it called a trade or whatever they want to call it with the old style apprentices. But if it's when you get to do stuff, you need to be able to do at least be able to speak to people about cases, and the best way to do that is to get them to do presentations during the course, teach them how to do bits and pieces, and be a bit more extrovert, even though they might be introverted. They need to practice and rehearse things like that. I mean, before I started doing any courses or any speaking or anything like that, I used to hate standing up in front of people. I'd just get embarrassed. And it was through the forces, not necessarily the Air Force, but when I was in the TA and I started, as you get promoted, you get sent on these courses, right? You've got to be an instructor to do this. You've got to do that. You've got to do something else. And they teach you a method of instruction, and then you develop a style. Some people have been in forces 20, 30 years, and they still teach the same way as they did 30 years ago because they haven't developed their own style, because everything's taught by this is what you do at first, second, this is third, this is fourth. And it's always taught the way they teach the slowest person. So if you've got somebody slightly more advanced, they're sitting in the class, like that. This is instructor's rubbish. But if you can get somebody who can recognize that and then develop your style of teaching or your style of instructing, then that's going to be a benefit to everybody. You've got to be able to keep everybody's attention, which is the hard thing.
Yeah. Can you just talk me through, you said that you had a massive learning curve when you went to do your clinical dental technology. So can you just run me through what that big learning curve was?
I think that the first day we were down there, I think the first morning was okay. So we had a little induction and we got shown around the areas where we'd need to be. We had a little tour. There's the library with no books. There's the factory where you get fed. This classroom where you're going to be doing X, Y, and Z. In the afternoon, we had lectures, and I just sat down and went, I don't even know what that is. I've never heard of this before. I've never heard of that. And it was just basic anatomy. I think we're first ones, and we're starting to do things like the different nerves, the 12 cranial nerves. And then after that, we had, I can't even remember the name of it, but it was basic something. And it was going on about cell structure and the different types of cell structures and things like that. And you standing there, I suppose it didn't help. He was an oral surgeon, a consultant oral surgeon, and he was standing there saying, but you should know this. This is basic. And he didn't know. And I just said, look, I says, you need to know the demographic of the class. I says, the last biology I did was in 1982. And that's it. That's that steep learning curve where you go, Christ, I've really got to start reading this. And I was worried, so worried. On my way back at the end of that, I thought, can I do this? I don't think I can. And I was lucky. I've a couple of friends who are CDTs, and I phoned them. I phoned one of them. I says, look, this is what he says. Don't worry about it, Sean. He says, just take it in. He says, and regurgitate it, even if you don't understand it. He says, eventually, when you get to the end of the course, he says, it'll all make sense. So it did in a way. It's you start looking at things and right, that's what he meant, and that's what he meant. But again, it's when you are instructing or teaching, it's when you stand there and saying, but you should know this. There's no such thing as a stupid question. And this is what I tell everybody: if somebody doesn't know something, they don't. But then they'll know something I don't know. Different people have different skills. And I'm not even going to say that the education level is different for people, but different people excel in different ways. Some in academia, others with working with their hands, others are really quick thinking and can do other stuff. It's like darts players when they're playing darts and subtracting. I can't do that. I got to work out a calculator. So
Yeah, same. So where did you actually do your training to be a CDT then?
That was, at the time, it was UCLan, University of Central Lancashire in Preston. And I think it's just now the University of Lancashire, I think it is now, UCL.
I think it's the only place doing clinical dental technology still, isn't it, at the moment?
Yeah. There was a course down near Kent, I think, but they got the teaching thing taken off them. They got looked at by the
Okay.
GDC. No, we're not happy the way this is taught.
Fair enough. So how did you manage that? Is it a full-time course, like Monday to Friday? I mean, if you've got your own business and things like that, how did you manage all of that?
Right, there was 3 semesters, sorry, of 10 weeks, and we attended once a fortnight on a Thursday and Friday. So we had the first term, we had Thursday and a Friday, then you got your next Thursday and Friday off, and then you were back down Thursday and Friday the following time. So really for me, it was Wednesday afternoon to Friday night, because I used to leave on a Wednesday to drive down. And all it meant was that for 10 weeks, I was working every day. I was doing catch up and then get ahead. So depending on what we were doing, and it
And
was
then you've got
quite,
your studies and assignments and revision as well on top of that, haven't you?
yeah. As regards to the course itself, they don't teach you much dental technology. It's all clinical governance, and you go down there and it says, "We're not here to tell you how to make dentures, just because you can all make dentures." So, but there are different things, and a lot of it is professionalism, that sort of things, how you treat patients, and the right way to work in a clinic, and things you shouldn't say to the patient, the things you should say to a patient, and
I
things
suppose
that
it's consent and history taking and all that kind of thing as well, isn't it? Documenting things properly in the notes.
It's things like that, medical history, looking at drug relationships. So look at any drug regime that they're on and think, all right, okay, this interacts with that drug. That's why you take the third drug, and this gives you this condition. Because one of the biggest issues with elderly patients is dry mouth, and it's usually because of all the drugs that they're on. So, and some of the drugs they don't need. They just counteract the side effects of one of the other drugs that they're taking. So, and the other thing as well is sometimes the patients, and I've had this quite a lot, and they just want to talk. They've got issues, so they just want to sit and talk about their issues and not get any treatment. So you just put that down, and it's great.
Yeah. I suppose some of them are quite lonely as well, aren't they? So it's the
Yeah,
only time they get to chat to somebody as well.
yeah, I think sometimes it's some patients you get they've got a lot of mental health issues and things like that, and they need to talk. They get in to see their GP, or they kind of get into counselling or anything like that. And I'm surprised at what my patients have told me about themselves. That's the trust that they have in you, I think, is a
Do you also think that it's the fact that they feel like you've got that time to give? Because obviously, when you go to a dentist or a GP or somewhere like that, you feel like you're on the clock. Like literally, you've got a 10-minute appointment. They're going to whack you through as quickly as possible. You haven't got time to sit and chat. Whereas I know when I'm sat talking to patients, they'll just sit and chat. And sometimes it's completely unrelated to dental or any reason why they're there. But I've got a bit more time to give them. And I think they seem to relax, and that does put them at ease, and sometimes a little bit too much at ease because you have only got limited time after all, haven't you?
yeah. Well, even me, I work on appointments, so I've got limited time, but I control my own appointment time. So I think the shortest appointment I have is 20 minutes.
Mm.
And, I've got some appointments 30, and some of the techniques I do, I'll take 90 minutes or 2 hours for an appointment. So depending on what we're doing. And people say, yeah, but it's just dentures. I said, well, it is, but it's the techniques we use to do that and develop it. And at the same time as well, I want to know about the patient. I want to know what they want and feel that they're being listened to, and, because they're investing in me, in my time. And I want them to feel that I'm not just in for 20 minutes and then 3-4 visits at 20 minutes and getting charged a fortune.
But if you understand their expectations by being there and listening to them and talking to them and letting them know what the options are or making them feel heard, you're going to make a better appliance, aren't you? Because you know
Yeah,
what
and
they
then the,
want
then the
from
hands
it.
let me down. In theory, but when you do that, you can then think, no, I cannot make that. So you can then, at the earliest opportunity, you can lower their expectations, which is very
Manage their
important.
expectations.
Yes, yes. I think The first time we went on clinic, the day before we went, we had a tutorial. The lecturer came in, there was 5 of us there, and he just said to everybody, he says, look, he says, just speak to your patients, make them feel welcome. Turned around to me, he says, Sean, don't speak to your patients. He says, nothing done.
Do you find that you get a lot of nervous patients at all?
Sometimes, yes. I've had patients come in and says, I hate dentists and I hate men. Well, at least I've only got one out of the 2 of you, because I'm not a dentist. You get that challenge straight away, and you just work through it. People who are nervous, and again, you just sit and wait through it. I mean, I've had patients in tears for the right reasons, not the wrong ones. So it's that, sometimes you could do the littlest thing for them, and I think you've torn up trees and everything to get what they want, and I'm thinking, yeah, but it just needs this done. There you go, that's it. And it's that as well. But I mean, I'm lucky because in general practice, I'll see their NHS patients, so you see everything, absolutely everything. Well, I'm seeing kids, but you see, 20, 30-year-old adults who've never looked after their teeth and have got to get a full clearance. You see people in their 70s and 80s, and they're worried because they're getting their first tooth out. And
that's good going, that is.
Yeah,
70s and 80s and only having your first tooth out.
Yeah. And it's well, I've never worn a denture. Or you get people they've got certain conditions, and you say, well, you don't wear a lower denture. Well, I've never been offered one. I thought, why not? If someone's got like a flabby ridge and just 6 front teeth, and they don't wear a lower denture, and I say, well, nobody's ever said. So is that education, or is that because the dentist has said, yeah, you need a lower denture, and they say, oh, I can't wear one? Is it can't, or is it won't? And this is
Could it be a money thing as well?
Well, yeah,
maybe.
it is. Yeah, be. And what I found is NHS patients, the ones who are exempt, probably get the best NHS treatment because they don't have to pay for it.
Yeah.
Which is a shame, but at the end of the day, it costs money, and there's not enough money in the pot to pay for everything. So somebody's got to make a commitment somewhere.
So you're also a tutor at Cardiff Met. What does your role involve there then?
I teach the second years on the foundation degree course in removable prosthetics. So that's usually the first term of every year, which runs from September to December. And I get them for an hour, 2 hours every week. And I just sit and I deliver the lectures, but I always put a clinical slant on it, because if you give a partial model to a technician and say design a chrome on that, they'll put clasps everywhere, they'll put rest seats everywhere. The thing will be brilliant, but they don't know the condition of the teeth. They don't know necessarily if something's in the bite or not, because the other one, yeah, just open the bite. Just open the bite, it'll be fine. And you can't do that. So I try and give them, everyone says, I was at a lecture, in fact, last week, and it was about digital dentures. And the guy giving the lecture and the demonstration says, yeah, he says, there's no communication between the dentist and the lab, and you've really got to communicate. And I'm thinking, hang on, I says, there's a patient involved in this. They need to be involved in that. And this is what I always bring up and say, there's not 2 people working, there's 3 people working for this. You've got to get this other person involved, because at the end of the day, the treatment should be advised by the dentist, completed by the technician, but led by the patient. So we know what's best for the patient, or the dentist should. So they'll advise the patient the best, and the patient will then choose from their options. Might not necessarily be the best, and then the technician's got to put that in. So there's all these. It's all right saying, why don't they do this? And why don't they do that? And it's because, well, the dentist might have asked, they might not have thought about it, and then the patient has decided, no, I want this, or I want something else.
And this is it. The patient doesn't always want what you think is best for them, do they? They want what they want, and you give them an option, and sometimes they just pick the thing that you wouldn't have suggested.
And they're allowed to change their mind as well.
And that's fine, isn't it?
Yes.
Yeah.
It's fine. But as a clinician now, if I don't think it's suitable for them, I'll just say, go and find yourself a dentist who'll do that for you then.
Have you changed? Has it changed your practice in the lab significantly since you've become a CDT and actually spent more time chairside with the patient? Has it altered how you work in the lab now, how you design your appliances. Now you've actually got that experience of both sides.
Because I'm designing appliances for myself now, I think my partial design is changed. As regards to bike registrations and special trays and things like that, I'm able now to do what I want, whereas when I've worked in other labs, it's been a case of having to do what they want. And I've had heated discussions when I've worked with in commercial labs as regards to the right size of bike blocks and the right design for special trays, and you need to know materials that you're using for special trays and stuff like that. And I've even had one of my employers come back. He went on a course over to Germany and he come back and he said, the guy over there does his trays the same as you, Sean. I went, aye, the right way. So, there's things like that. It's people say, but when you do your course, if you've worked in, do you both work in a commercial lab, or have you? I know you've worked commercially, Andrea, before, haven't you? In a
Yeah, I
commercial lab.
started out in a commercial lab. It's been a while now, but I did start out in a commercial lab.
What
Yeah.
about you, Jenna? Have you worked in a
Private lab.
private lab?
Yeah.
So, you ever did when you went to college or university and come back? Did you ever say, yeah, just don't worry about that. We don't do it that way. We do it this
I-
way.
Yeah, I think every lab, to be honest, has their own way of doing things. They do. And they like to teach you their way because of the things that they've learned and what works best for that lab. So I'd say so, yeah.
So when something goes wrong, right, and if you've only been taught a particular way, if something goes wrong, and you think, well, I've been doing it this way for ages and it's worked all of these times. What's gone wrong? And the way to fix it is go right back to basics and think, okay, I'll look at this, I'll look at that. How can we actually change that? Let's see. I pull this one out the hat all the time. Bite blocks, 22 mil and 18 mil, too high. And there was research done in probably the late 90s, and I think they work out at 18 on the upper and 16 on the lower. That's probably the best height, because in 90% of blocks you're not reducing, they're just bang on, and that's how I do them. And what else I hate as well is when they're too thick at the front. When you see them out at commercial labs, they just stick the wax on and it's just there, and you think, and what all I do, and I've had them like that, and you spend all your time scraping it out at the back, because part of the speech and part of the trimming of the blocks is, for me, it's just as important as getting the OVD. But you need your OVD, and then you need your ICP as well, or your RCP, whichever one you're dealing with, whether they're dentate or whether they're edentulous. So there's things like that. But I started off clinically taking my time and doing stuff right, and now I can still take a bite quite quick and trim the blocks and get everything right just by looking at it. Sometimes just by looking at the patient. I still use the Willis gauge. I still use the Fox's bite plane. I use an Alma gauge if they've got their old dentures. So, it gives you a gauge of whether if the dentures are too big, I'll use the Alma gauge and say, right, this is too big. So once I get the blocks made to the Alma gauge, I can just reduce them and it's all done. But then other systems like BPS, you need extra appointments, so you do that as well. But I try and not, when I'm teaching on the course, I try and not overload them with too much advanced stuff. I just want basic answers to basic stuff, and providing they get that, and it's not necessarily learned by rote, but just think about design. You think about what you want, what you're going to replace, and then work back and think, right, how am I going to design this? Where do I need to start? Right at the start, rather than, I need a special tray and get a special tray, and this is, or it should have been in this material, or the impression should have been something else. You have to think logically, and if you've got your end point, what you intend to do, and then you'll say, right, I only need this amount. I only need, it's very difficult to try and get across sometimes what you're doing. But then when we're instructing, we're there to give them the information. The mentors are meant to give them the
I think
skills.
some stuff only really sinks in when you actually try it yourself.
Yeah.
So having you saying, this is the way you should do things, or these are the things I suggest, or these are the different tools that you can use, until you actually, because we're very tactile trade, aren't we? So once we actually get stuck in and start doing it, then we'll be like, oh, now I know what he was talking about. Oh, now it makes sense. Yeah.
It's like surveying. I've got that lecture to do, and it's the most awful lecture to give when you've got a surveyor and you're trying to survey, because 90% of surveying now is you click a button and it's done. It's brilliant, but it doesn't teach you how you get from A to B for that. That's the hard part.
And
And
understanding what's blocked out and why. Yeah.
surveyor, try and teach what a surveyor does. It's an awful thing. It's an awful lesson. You know, plus it's so time consuming as well. When you survey a model.
When you're in the classroom with your students, what do you find the most like technical mistakes that they make, the common ones?
I just get the work at the end of the semester. I get the work then to mark and have a look through. When I get they've got like 5 pieces of work I've got to do, because all the lessons that we give are online. We give them the information and then they go back and I think say things like they'll I'm trying to think of the best way to put it. I know
So
what I
you
want to
teach
say, but
remotely
it's
then?
yeah, everything's done remotely, and it's a kid. You look at you can't make a silk purse out of a sow's ear, and so you'll get a full denture or a full denture, and it looks lovely. You put it on the articulator, and it doesn't articulate together, and then you think, right, yeah, the teeth are in the wrong place, but they've spent all this time with a composite and the stuff to make it look nice, but it's absolutely no good whatsoever. It wouldn't fit the patient's mouth. I mean, when they don't even fit the model that they're made on, for a start, that's the
I mean,
other
that
one.
is a definite red flag, isn't it? Because we always go, like, if anyone sends anything back, you'll be like, it fit the model.
Model, yeah.
It
Once
fit
said
the
to me, that'll
model.
be on my
We always
gravestone.
make everything fit the model.
So just to get this into my head a bit better then, so you do these lessons remotely. Do the students
Yes.
go into classroom and have, technical lessons with a teacher as well to know how to set these things up properly, or are they doing it by themselves with advice online?
Right. The way the foundation course is run, it's most of the students are online themselves as well. So they're just watching at home or at work because they're all over the country. I've got students in the Republic of Ireland, Northern Ireland, Wales, Scotland, south of England, and they only go to the university to do they've got 2 or 3 pieces of work that they've got to do. They get a week to do it, and they go down, and the instructors there will oversee them and show them that. So for them to be on the course, they must be employed as a trainee dental technician as well. And part of that, there must be a mentor who is able to, well, not able to teach them, but they should be teaching them the actual subject. Now, I found that there's a lot of the mentors, if you say it's a Crown and Bridge heavy lab, you can't really get a ceramist as a mentor because they like to call themselves a ceramist rather than a dental technician. And special tray, oh, no, we don't do that. Wax, oh, no, we don't do that either. No, they've just got to put that 0.5 millimeter on
Don't know
top
what
of
you
a.
mean.
Says the Crown and Bridge Tech in the corner.
Oh, I mean, I can sit here because I've done Crown and Bridge. I'm rubbish at it. I've done it. I've done ortho. I like bending the odd wire, and I do dentures. So, if somebody says, "Can you wax up a crown?" Yeah, I can wax up a crown, but it might take me a bit longer than anybody else. But you'd get a functional crown. So, even if it's a flat top and just polished around the sides, nice and square, it would go on and it'd be just out of occlusion. So, got to keep it
So
out of it.
if you get anybody that wants to go on from their, being a dental technician, going on to be a CDT, especially later on as well, like you did, what advice or, I don't know, practical or technical skills would you say they need to practice before going in and actually doing that course? Is this,
They've got to be prepared to I think not necessarily be shocked, but go in there and completely relearn anatomy and physiology. They've got to relearn stuff that they'll be really, really uncomfortable with, and try and get out of the, well, what do I need to know this for? Because I'm only making dentures. It's not. We're trained to spot abnormal tissue. I'm not even going to say disease or anything like that because we're we're not trained to. We can't diagnose. So we can see something and go, don't like the look of that.
are you able to refer if you see
Yes,
something that you don't like the look of?
but there is a referral pathway, so we can do that. But I think for every white patch and every, coated tongue or every bit of denture stomatitis, we know it's denture stomatitis, but we can't diagnose it. But you're not going to refer it, are you? You're just going to give them, oral health, denture cleaning advice. If you know that general practitioner, can you get them some antifungals, that sort of thing, and then perhaps, whether they need a dose of antibiotics or anything. You get patients in and you think, yeah, you've got an abscess there. You can see the lump and the pimple on the front, but I cannot say, yeah, you've got an abscess. I've got a chap on the door, and can you come and tell the guy he's got an abscess?
Do you feel like you work closer with the dentist being a CDT, or has it not changed?
Well, I work in general practice, so there's usually 6 or 7 dentists there when I'm there. And the principal, he works next door to me, and he comes and asks me for advice, and I go and ask him, if he's got denture cases or things like that. And he's an implant dentist as well, so he places implants. Hates doing dentures, and he says that's great. The beauty of it as well is with the I don't want to call it the new scope of practice. It's just a simplified version of the old scope of practice. Because what it does, it's now saying you have a pathway to go and do something else, providing you're suitably trained, competent, and suitably indemnified. So there's ways and means where, as at your basic qualification, you might not be able to do something, but there's nothing stopping you going on and learning and doing something else for, say, like fixed hybrid dentures. So be able to take them out and put them back in again. There's a course like that because you're still not doing anything invasive. And it's only the invasive treatments that you obviously need to go on and either perhaps do hygiene or dental therapy or something like that to do certain other things. So providing you're not cutting tissue, and we're saying that we can take stitches out. So what
It's
is the dentist
extended
says?
scope, isn't it? We're
Yeah,
utilising more of the team and allowing them to have a suitable training within the scope of their own field. Yeah.
So
Yeah,
it's
I
like
think
saying,
there's definitely more out there that technicians, clinical dental technician, therapist, hygienist could actually do. If they extended
oh,
that better, even more so actually.
he could probably do a frame assessment. What do they mean by a frame assessment? Is it a chrome frame or is it a frame for an implant frame? In which case he's then he'd be supervised, but as part of that training, he needs to do the proper hand washing and how you dress in surgery and stuff like that. There's all of that and the professionalism with the patient, and that puts a lot of technicians off because they just want to, they don't want to speak to patients, do they? They don't want to have their hands in a minging mouth or.
I mean, this is the thing, but with our profession, there's room for both, depending on what type of person you are and how much you want to interact, isn't there? I mean, moving on from that, I mean, how much do you think digital technologies are starting to affect the CDT world now? Are you doing much digitally, or is it still really not suitable for the type of work that you're doing?
It's a tool that can be used. I do a lot of chromes and I do them digitally. I'll still take an impression
Mm-hmm.
and I'll scan the model from that impression. I get my chromes made digitally. I've got my own printer and I've started scanning everything that comes in now so I can do special trays because they just get printed off. It takes about 3 minutes to design a special tray in the software, and it takes about 40, 50 seconds to scan it. The longest part is putting in the patient's details. It's the worst part. And working out where you're putting it. I've got that many folders, and right, this has got to go to this one, and that's got to go to that one. And I spend more time thinking, Christ, where have I put this now? Looking for a file on the computer.
Have you used any of the new printable materials yet? Lucitone, anything like that?
Not use the Lucitone because that's got to be cured in a certain way. Heat and light cure. I've got what do I use? I use a lot of the special tray resins for models. Say I get a file in, I need to print a digital model. I'll just use cheap model resin because it's not going anywhere. I don't need dental resin. It's because it's not getting worked on. It's just purely a model resin. And for other things as well, I've actually got a filament printer, and I've been trialing that out to see if I can just get models for that, for retainers and things like that. So the filament printer, I don't know if you can see it behind my shoulder, but that's a filament printer. and it's great. So I've done a couple of models with it, and what else have I done? Millennium Falcon.
Everybody has to do something non-dental when you get a printer, haven't we? We've all got to play about.
I've got a clock as well somewhere. I've got the Death Star on a clock.
Oh, have you? I got an
it's not
articulated
finished yet.
axolotl.
Right, it's not finished yet. I'm busy painting it. So, well, I've also got I'll just switch this round again. I've got a resin printer there. That's busy printing at the moment. So hopefully that's.
So you just do these for models and things at the minute and special trays. Would you do denture bases digitally at all?
What I've got in there, I've got a hard base for a try-in, so I can assess the try-in on a stable base, and at the same time, if I need to, I can take a closed mouth functional impression.
And how do you find that works compared to the conventional way of doing it?
Really good. All I'm doing is with the hard base, I'm just doing it digitally rather than laying a hard base and trimming it. When you do the BPS system, you're making Gothic arch appliances, and I find I can do that with I can lay the base and then just build up on the base if I need to for the Gothic arch. There is software which I've got that you can. It's in the 3Shape software, but I've not managed to make the digital nathometer yet. So that's a learning curve that I'll have to do, and I usually do them at home. So I mean, I'm at work now, but only because I've got this meeting tonight. I thought I'll just stay and do a little bit extra. So I've just been doing bits and pieces here. That'll save me tomorrow. And hopefully my special trays will be ready. 1% to go. 2 layers left, it says.
So I'm going to stay on the digital aspect of things. How do you see digital technology kind of changing the industry and moving forward?
Crown and Bridge I think is going to go 100% digital completely. And it's going to get there that you'll not need a ceramist, I think, at some point. It'll just be somebody staining and glazing. It's about the knowledge behind the CAD then, is you've got to be able to look at form and function, and not just make a beautiful crown on a screen. It's got to function well. So occlusion is going to be massively important, and it's something that if you get it right in dentures, right, it transfers across. But dentures has been so poorly produced probably for the past 50 years with the NHS standard of dentures, cheap, bulk, chuck them out the door, and that's why people have got loads of issues with dentures. But you'll see it as well with TMJ problems with crown and bridge. If you get a beautiful crown and it's just not quite in function, you get things like that. And
do you think that's because, when you get NHS dentures, so to speak, you've just got normal technicians, you've got dental technicians that, labs that make a lot of dentures, but they're not necessarily clinical dental technicians. Do you think that just standard dental technicians should learn more clinical aspects for making dentures?
It's not the manufacturing of them, it's the money you get for them in commercial labs by the NHS. It takes between 4.5 and 7 hours to make a full denture. And if you work that out for the price that you'd get for fulls is what? Well, up in Scotland, it's the dentist would get nearly £400 for that. He's got to pay his lab bill, right? So you're looking at, say, 200 quid for a set of full dentures. The lab's got to make a profit. Where's the salary come from? We shouldn't be paying. Everyone says technicians should be paid more. Yeah, I agree with that, but it's that market.
It's the race to the bottom prices, isn't it?
Until labs stop trying to undercut everybody and say, right, I've got to pay my technician £25 an hour or 20 quid an hour, whatever. He's got 20 years experience, right? And it takes 7 hours to make a denture. So there's 140 quid up to say £200. And then you've got your materials on top of that. And then which other service industry would go and pick stuff up for you and drop it off the next day, personalised?
Well, you've got your overheads as well as your business, haven't you? It's there's so much more associated with that.
Yeah. And I mean, I managed to do my stuff here, and I do my stuff clinically. And my principal up in Kirmia, he says, Sean, you're too cheap. I says, well, the thing is, I said, you've got to look at your market, and you get NHS patients who want something a little bit better. So I'm just saying you just extend the clinical time, but there's a cost time ratio and also material ratio, and people say, well, what do I get? Is it better teeth? Is it better plastic? And there's some people, no matter what you do, right, they'll still end up with the worst denture in the world because they'll never ever wear or get used to wearing a denture, and yet you can give somebody something which is, you think, oh, Christ, that's awful, and they love it. And it's not
It
that
is a
low.
mindset
We're
with some
trying.
people, isn't it? It
It is,
definitely is.
yeah.
You can give some
It's
people the
difficult.
most amazing thing, but if they don't want to wear a denture, if they've just got this thing about not wanting to wear a denture, don't matter how good it is, does it?
No, there's other aspects as well. You see, well, I got this denture and they've done all of this and all of that. I says, yeah. So you've got all this lovely contour and stipple and stuff like that. I said, but you can't keep it clean, can you? Why put it on? Can't keep it clean, nice and smooth. There's no sharp edges in the body. The only sharp edges you get is when you break something.
Glue it back together. Do you get patients come to you that's glued the dentures back together?
Yeah, and that
We
been
all
chewed up
do,
by
don't
dogs.
we? We all
Chewed
do.
by dogs. My dogs chewed my denture. It's in like 6 pieces, and you go, you see everything, absolutely everything. That's what I like about it. You see everything, but sometimes it's some of the stories you could tell. I had a patient once, she had a part of my denture, right, and she'd put it in 20 years ago when she got it, and it's never been out of her mouth.
I
Right.
had a patient who actually had a denture and then one of his teeth fell out. So he ground it down and actually attached the natural tooth to the denture himself. He actually did a fabulous job. I mean, it was a bit weird and gross, but he did a brilliant job.
Partial denture last week, 2 teeth, and the guy came in and he'd lost his tooth. His tooth had come out, and the dentist had cut the root off and composite bonded the tooth back in.
I do, brilliant.
The bridge, and it fell out. And I went, he says, can you not put it back in? I went, no. I says, I can't. I says, you come here for a denture. Well, where's my denture then? I says, well, I've got to make it. Well, can you not just put something? I says, no, it doesn't work like that. So they were expected to come in and get a new denture there and then. I've come from a denture, not realizing that, you've got to take impressions and, well, it was just a single tooth. So I didn't have to worry about a bite or anything like that,
Yeah.
Impression, special tray, and then, straight to fit in the end. And then he wouldn't come in to get the composite taken off the back of his tooth. So he's got a shelf of composite sitting on the palatal of his tooth. So I've had to make the denture to fit around the composite. Honestly, you cannot make up what you see. And you get patients coming in, and they need like 8 teeth out. And they're breathing in and out, and you can see the teeth moving. They're that bad. There's like a shelf of calculus on the back,
Yeah. That's the only thing that's holding them in.
You're not doing anything, and you're going, no.
Sean, we are coming towards the end of our podcast now. So there's just a couple of things just to finish off with. So what's your most rewarding moment of your career so far, and what keeps you enjoying dental technology?
I think it was probably just about a couple of months ago, just before Christmas. I had a patient in and she needed a full clearance, and she was very nervous and she didn't want teeth out. And we just sat down and spoke to her and explained the whole treatment process to her. And I said to her, will you trust me? And she went, yes. And she got her teeth out, fitted her dentures, and she came back, I think, the week after Christmas in tears of joy, because she says, she says, I can smile again. I've not been able to do that. I've had to do this all the time when she's smiling. And I tried to make, it was just an NHS denture as well. So she had 2 laterals missing, overlapping 3s onto the centrals. And she says, can you make it look like that? And I went, yeah, we can do that. It's not a problem. And she come back. And then I had another patient just last week, came in with a bottle of whiskey for us. And I thought, what, another one? So I'm still trying to get through all my whiskey from
your birthday?
From my birthday, yeah.
Yeah.
Right, just before you go, I'll see if I can get this. It's just on the plate. It's just finished printing. So just to show you that I have been doing some work. There we go.
Looks like you need a new chair though, Sean.
Yeah, I know.
Oh, nice.
This chair. So I've got 3 special trays there, and then I've got a clear base. It's blue, but I'll just set up on the clear base on there.
Looks fabulous.
So I'll just see what they're like in
Take
the
them
morning.
off and give them a good clean. Now, do you are they the ones? Is that just your normal resin that you clean off with alcohol and light cure after?
Yeah, it is special tray resin, so it's biocompatible. But yeah, just clean it off with alcohol. So
Yeah.
stick that in the alcohol bath overnight, and that'll be fine for in the morning.
Well, thank you very much, Sean. It's always
Problem.
an absolute pleasure to talk to you.
That's only because you like my crack. That's all it is. It's
Will you be going to any of the dental shows? The dental show coming up, DTS?
BTS, yeah. I don't know. Is that a secret, Andrea? Is it or not? It's not a secret.
No, it's
Actually.
not a
I don't know.
secret.
I've got a session on a Saturday lecture to do, and also I'll be helping Andrea on her stand, talking shite and getting drunk. That's what
Lovely.
we usually do it. That's what we usually do.
Come visit the
at
Dentec stand and watch Sean get drunk and talk rubbish. It will be entertaining.
That'll make all three of us there then over Friday and Saturday. So get yourselves down there, come and give us a visit, and we'll end it there. So thank you for joining us, Sean. It's been a pleasure.
Right, thanks very much for having me. It's been great.
Thank
Thanks.
you.
Take care.
You too.